Hello, everyone. This is Alicia, Dave, Jordan, and Miranda, and we are presenting patient case number 3, Sarah Johnson, who has a traumatic brain injury. A description of the case. To start out, patient is a 57-year-old grandmother of 3. Current onset, patient was struck by a car while riding her bike, and at the hospital, patient was diagnosed with TBI with amnesia for events prior and after her injury. Patient was able to move extremities but is confused and could not identify herself. Chief complaint was constant severe headache and various body pains, skin abrasions and contusions, and 2 black eyes. Patient's medical history is insignificant. However, there is a family history of diabetes. Patient was monitoring her dietary intake to prevent complications. Medications, patient is not on any medications at this time. Living environment, patient currently lives with her husband in a 2-story house in which her husband tends to most of the chores. Prior level of functioning, patient independent in all ADLs and IADLs. However, patient's husband tends the lawn, garbage, and cleans the dishes after meals. Patient's husband reports both being content with previous lifestyle. Occupation, patient is an enthusiastic homemaker. Patient's husband works full-time in maintenance for a high-tech company. Social history, patient enjoys riding her bike and quilting, and she is also active in her church and makes baby clothes, which she donates, and patient annually expands her flower beds as well. Here is a flow chart of the ICF model for our patient. First, the patient's health condition is TBI with amnesia. Body functions and structures contributing to the patient's current condition include decreased range of motion due to muscle pain, pain from multiple contusions and abrasions to her trunk and extremities that also limit the patient's movement. Patient is oriented to herself and family members, but she can't answer simple questions about her family, such as her granddaughter's birthday. Patient's attention span is decreased, as well as she's easily distracted mid-task. Patient requires minimum to moderate cueing when performing tasks such as bathing, dressing, grooming, and transfers. Most cues are needed to help sequence tasks or to locate items or locations in a room. Patient's mobility is slow but independent. Next box. Patient's activities include independent with eating, toileting, and clothing management. Patient is able to answer structured questions such as what do you put on first when you're getting dressed, and able to carry that out. Patient's limitations include needing min to mod cueing with sequencing tasks such as completing a brownie mix. Patient is distracted easily and uses a Versus frame for bathroom transfers. Patient's restrictions include driving and bike riding. Patient should be supervised due to her decreased cognition and memory at this time. Patient's internal environmental factors include the patient being health conscious prior to her injury, and patient is also motivated to be able to play with her grandchildren again. However, patient's memory is decreased due to her injury, which is a negative internal environmental factor. Patient's external environmental factors are that she has a family living close by that is able to help, and patient also wants to be able to winter in warmer climates. However, patient's children are very busy with their own families, and patient's husband is struggling to cope with the changes that have occurred due to the patient's accident, which contributes to negative external environmental factors.
Okay, again, some of these are the functional problems we highlighted that we potentially want to work on with the patient. Sarah ambulates without an assistive device but moves very slowly and speaks slowly. Her range of motion is limited due to pain such as muscle pain and pain from the abrasions and contusions from the injury. And she also has a slow reaction time. She also has decreased memory and is unable to give detailed information about her family, such as birth dates, etc. She has difficulty with divided attention and abstract tasks, as evident when instructed to gather toiletries and clothing for self-care. She has trouble generating plans and is easily distracted and often wanders looking for items. Some of the plans, as far as generating, include dressing and bathing. Patient shows conservative scanning and requires minimal cues to locate objects. She requires moderate cues to locate environmental cues for orientation within the hospital. She has difficulty remembering what items are located behind closed doors, such as the bathroom, and difficulty remembering what's in closed drawers. She requires cues for tub transfer, as well as locating and gathering items for bathing and dressing. And she requires moderate cues for baking due to safety, and she needs supervision for bed making. Some of the goals we came up with: patient will be able to ambulate independently out of a hospital room, down a hallway approximately 50 feet, and be able to locate nearest bathroom door in order to return home. This will help the patient ambulate around the house independently when her husband is not home. This will also help the patient improve scanning and locate objects in space. Finally, it will also help the patient better locate destinations that are not visible, such as a closed bathroom door. Next, the patient will be able to report decreased pain, which can help improve range of motion, mobility efficiency, and reaction time. Another goal would be to be able to complete a reasonable 15-word crossword puzzle in less than 15 minutes in order to help the patient avoid distraction and improve attention. Patient will be able to recall detailed information such as birth dates 8 out of 10 times in order to improve memory. Patient will be able to perform tub transfer, bathing, and dressing independently in order to care for herself when she is home alone. Patient will be able to bake a batch of cookies safely and independently in order to prepare meals safely when home alone. So a lot of these goals will focus on more independence, so when the patient's husband is out of the house, she can perform these activities. Patient must understand that like her desire to winter in a warmer climate might be limited due to her recent injury, and we can make adjustments accordingly.
Okay, for in general, the interventions we wanted to have Sarah perform are range of motion exercises. These will increase as the patient continues to heal and there's less pain due to the abrasions from the accident. Balance training, and with balance training, we want to increase the efficiency of her movements. It states in the case that she has good balance and relatively good posture, but she's just very slow to move. We do some therapeutic exercises just to continue to condition her for return back to her home environment. But primarily we do functional training treatments. She struggles with a little bit with transfer training, getting down, sitting on the toilet and getting in and out of the bathtub. Also, she's using a chair in the bathtub, so that transfer's causing her some problems. The patient also, like we've mentioned, struggles with sequencing activities, whether it's bathing, cooking, dressing. She's able to do them, but requires cueing, so we'd work on those. The patient's relatively high functioning considering the accident, but again, just needs assistance with sequencing, and she struggles with keeping and maintaining attention. Initially, early on, treatments will consist of restorative treatments in nature, because we're not sure just how much the patient is going to get back, and then as we determine where the deficits continue to lie, we can go into some compensatory interventions.
Okay, these are just a few of more specific and detailed interventions we came up with. The first one would work on attention and memory. You could have 4 cups turned over with a small object underneath one of them. Place them in front of the patient. You can scramble the cups and encourage the patient to stay focused on the cup with the object underneath. This will force the patient to um, stay on task and avoid getting interrupted or distracted. Another task we could have the patient do is to demonstrate and perform proper technique and sequence for self-care activities such as bathing, dressing, and cooking. This can help improve independence and self-care activities and also memory as far as generating plans to perform the activities. And finally, a more functional task, the patient can be seated at the edge of the bed edge of the bed, and she can be encouraged to scan the room, locating objects such as a room entrance or bathroom. The patient will then be instructed to stand up and ambulate towards the closed room door. She can open the door, ambulate into the hallway, continue down the hallway while the therapist asks her to recall certain family details such as birth dates. This is more multitasking and can improve scanning, mobility, memory and attention, and spatial recognition.
So for the plan of care for this patient, ideally you'd like to see the patient twice a day for about an hour each treatment. The patient struggles with memory and attention, and she's keeping a memory log. So you'd want to try to keep your training or your PT time consistent each day. Like I mentioned earlier, use primarily functional treatments, and then as you continue to see the patient, you'll reassess every 3 to 4 weeks to determine their rehab status and their potential, and determine how much more physical therapy is required. In order to progress some of those treatments, a big thing would be decreasing the verbal cueing during sequencing activities. You can also increase the complexity of the tasks. For example, performing tasks that require more steps. So instead of just like dressing, adding on coats, hats, gloves, and things of that nature. And in terms of increasing difficulty of balance and mobility tasks, you can progress those by, requesting the patient increase the speed, which is one thing she struggled with. You could also change the surface and include other distractions to help her maintain attention during these activities.
Overall, Sarah has a pretty good rehab potential. She had limited previous comorbidities. She had a family history of diabetes, and she's getting older, but those shouldn't have a large impact on her recovery. She may have wound care needs in addition to her memory impairment, so that could cause some problems. Psychosocial factors involved with this case could be her husband wants to return back to normal as soon as possible. Her children are providing care, but they're busy. They have their own lives, and she's a homemaker, so her role in the family could be affected by her injury. Some age-related factors that could be involved. She could have some delayed skin healing, impaired vision as she's aging. She may already have reduced anticipatory and reactive balance, so that could impact her recovery. She may have some reduced serial learning, so in therapy it might be necessary to break things up into chunks instead of throwing a lot of things at her all at once. And her age could have an impact on her memory, especially her explicit declarative memory. So she might not be able to recall things as well as she could in the past. Some factors and their potential outcomes, some positive factors that could influence her. Her family seems very motivated, and she was previously very active, and she has some support from her church friends, so those could be good for her. Some negative things, her husband doesn't seem as involved in her recovery as some other cases might be, so she could kind of feel lonely without her husband or not very supported. She also may feel obligated to return quickly back to how her prior level of functioning. and so she might push herself more than she should, and she also could be confused and not really quite understand what's going on. Oh, that's me. Sorry. Article. This is our first article summary. This article was titled "Objectively Assessing Balance Deficits After TBI: The Role of Computerized Posturography." And this was a pilot study on patients with severe TBI and their effects on balance. And the reason this study was done was because the authors found that standardized tests often used, such as the FIM, don't specifically assess balance, and they wanted to quantify some postural instability instead of the more subjective tests like the Romberg or Berg that are usually used with TBI patients or patients with TBI. The CPT, computerized posturography testing, it allows for an evaluation of static and dynamic balance, and the subjects in the study completed the 6 conditions on NeuroCom, which make up the sensory organization test, to assess their ability to ignore inaccurate information. And here's just a reminder of what the SOT looks like. Eyes open, and you can read what the thing says and look at the pictures, but that's just a reminder of the conditions. And the findings of this study show that using CPT post-TBI can quantify postural instability even if the ceiling is reached on another scale such as the FIM ambulation scale. And also showed the increased reliance on visual information to maintenance of balance post-TBI, even if inaccurate. So the patients had the most problem with inaccurate or lack of visual information to maintain their balance. And the clinical relevance, not all clinics have a CPT available, but it is a valuable tool. And even if you don't have a NeuroCom available at your clinic or with your patients, you can still use the ideas from this study to work on balancing using non-visual strategies to increase their balance when vision is inaccurate or not available. The validity of this study, the internal design control, the normative data was provided in a large age range than what the subjects were actually were. It was about 20 years difference. So, and they were provided from the NeuroCom manufacturer instead of the authors of the study getting some normative data. And the treatments post-TBI prior to testing were not documented, so there was lacking some information about the patients, and it was a retrospective design. So again, more specifics about the injury, they could have had inner ear damage or fractures, and that wasn't included in the patient chart. The external sampling validity, the sample size was small. There's only 21 subjects, and 20 of them were young males. So more studies need to be performed to assess, validity in female and older populations. And this study was also performed in acute comprehensive brain injury rehab clinic, so they could have had more specialized treatment prior to the CPT testing, so that also needs to be taken into account as well. The limitations of the study, it was retrospective, and they also used the criteria of severe TBI as amnesia lasting longer than 7 days, and this may be different than criteria used in other clinics. Again, the sample size was small and mostly male. Future research could include, like I said, female and older populations, and it also needs to include information about blast injuries and their associated inner ear damage and the effects on postural instability.
Okay, the article that I reviewed was an evaluation of an aquatics program on fitness parameters of individuals with a brain injury. The purpose of this article was to determine how effective an aquatic exercise program or an aquatic therapy program would be for individuals after a TBI. And the results showed that there are actually many different aspects, many different physical benefits that patients post-TBI have, including increases in balance, increased strength, flexibility, range of motion, cardiac fitness, and many other categories. This is a randomized controlled trial. There was an experimental group and a control group that both went through a class. Well, the control group went through a class that was just about reading and writing post TBI, and the control group obviously went through an aquatic therapy, or excuse me, the experimental group obviously went through an aquatic therapy program. In terms of internal validity, they had a good control system, like I just mentioned. They were able to accumulate a large amount of information with their measurements. They had relatively easy pre and post test measures, including basic range of motion, strength testing, and then cardiac fitness. In terms of external validity, there were a small number of participants with only 9 in the control and 9 in the experimental group, and it wasn't entirely randomized. They sort of matched up the number or the demographics of the patients to try to make even numbers of male and female in the control and the experimental group. In terms of future research, they need to, there's a whole area for more acute patients. A lot of these patients were well past a year after their injury. Also, the age range of the patients was between young 30s and upper 40s, and there's not a whole lot of research that's been done on younger populations and also on the geriatric TBI demographic.
The article I reviewed was about virtual reality for movement assessment and rehabilitation in patients with TBI. It was a correlational research study that included a within-group design that investigated the extent of relationship between the use of the Elements virtual reality system and how it may improve upper limb functioning in patients with TBI. The Elements system was designed as a supplement to current rehabilitation interventions. So there was a combination of traditional physical therapy and the Elements system. It demonstrated improvements in movement, speed, accuracy, and efficiency. Significant improvements in speed and efficiency were observed in the right hand, which was the dominant hand of all the patients, and accuracy in both hands. And it provides virtual reality provides the patient with increased motivation and engagement due to stimulating the environment, thus leading to improved memory and attention. Following the study with virtual reality, there was also fewer symptoms of dysfunction reported. Some of the issues with the study, as far as external validity, it was a small sample size, as there was only 9 patients, all of whom were under 50 years of age, and they were all able to have the cognitive capacity to provide informed consent and understand the virtual reality programming. Some of the issues of internal validity, the element system is still in the early stage of evaluation, so there's not enough data yet to conduct a randomized control trial, which is usually considered the gold standard for research evaluation. However, this study was actually a follow-up study to another study that showed positive effects of virtual reality for patients with TBI. But some of the limitations of this study is it might not be able to be generalized to patients above 50 years of age or low-level functioning patients due to the limited patient population. Future research should investigate the effects in patients with TBI with larger sample sizes in order to more adequately explore correlates such as severity of the TBI and time since the injury.
All right, my article was titled The Benefits of Exercise Maintenance After Traumatic Brain Injury, and it was just about maintaining aerobic exercise after traumatic brain injury and how that improves a patient's mood, quality of life, and mental health. It was a randomized controlled trial, and there were 40 patients, 15 men, 25 women. They were all 6 months prior. They received hospitalizations due to their TBI, and they were between the ages of 18 and 55. The dependent variable was patient's quality of life, mental health, mood, etc. The independent variable was the amount of exercise and the maintenance of the program and how those correlated. The results, patients that had increased minutes of exercise per week, they improved their quality of life at about 90 minutes of exercise per week. And then the maintenance was found not to be upheld in some patients, but there's other factors that contributed to that. We just had some clinical pearls for you from this case and the research articles that we found. So here they are.
Postural stability deficits may still exist even after the patient has reached the highest possible score for the assessment.
Aquatic therapy is beneficial for many different physical categories. Again, balance, strength, flexibility, and cardiac health for individuals who have sustained a TBI.
In combination with traditional physical therapy, virtual reality can show increased movement speed, accuracy, and efficiency.
And maintenance of an aerobic exercise program can increase patients' quality of life and mental health post-TBI. Like we talked about before, compensatory versus restorative treatment in this case, we just thought that focusing on restorative exercises first would be beneficial for Sarah, just because we weren't sure exactly what she would be able to get back, because every patient with TBI can respond differently to treatment. So just kind of evaluating how much she will get back in her cognition and functioning, etc. And then later on in treatment, deciding what compensatory strategies we would incorporate. And then also just working with patients that have had a TBI, it can require a lot of patience and understanding because they might have a decreased perception and cognition. So just keeping that in mind and being sensitive to the patient's family and the patient's needs as well. Thank you, Miranda. Here is our bibliography and our resources from articles and our presentation. So thank you all for watching, and yay, go Michigan!